Thank you for joining my presentation on communication of end-of-life decisions. My name is Terrence Shenfield, and I am the co-owner of A&T Respiratory Lectures, and I am formerly an education coordinator at a major trauma center. This topic is a very interesting topic. It describes many of the aspects of ethical decisions that go along with end-of-life care. The objectives for today's presentation, I will be speaking about what are advanced directives and how they impact end-of-life care. I'm going to be talking about some of the moral stressors that us healthcare practitioners go through. We see death every day. We're in the ICU. We see people dying. We see families under stress. We are under stress dealing with this every day. I'm also going to be talking about futile care. What is futile care? Futile care is when you take care of patients and the end result is you know they're going to pass. They're not going to survive out of the ICU. Yet everything is thrown at these patients to keep them alive. This causes a lot of stress in family. This causes a lot of stress in the healthcare practitioners. So we'll talk a little bit about futile care. And then very importantly, I'm going to be talking about methods of communication with patients and family members. When end-of-life care is involved with a patient, palliative care or hospice, we really need to be able to communicate effectively with the patient as well as the family members. We need to be able to communicate within ourselves. So I'm going to go over to some strategies of communication on topics of end-of-life, and hopefully we could all learn a little bit from it. During my career at a major trauma center in Newark, New Jersey, I was the education coordinator, but before I became the education coordinator, I was one of the surgical intensive care therapists. And I spent a lot of time up in surgical intensive care, and we were a major trauma center, like I said. And as a result of trauma, a lot of patients didn't survive. Many times I've witnessed this picture you see right here. I've seen families get together. I've seen a patient in an ICU bed who was in a major motor vehicle accident, or they had some major head trauma, or if they had gunshot wounds. I've seen it all. And there are many times when families have to make a decision whether to continue care or to stop care that's being given. And when you get any particular family member, everyone thinks a little bit differently. And there's so much stress involved with these decisions. I've been through this 100 times, like I've told you. So you need to have a good system to understand, to communicate to these patients and family members. And a lot of times you got to make a decision what's best for the patient and not necessarily for the family. A lot of times families believe that, there's a miracle going to happen. Some way their family member is going to survive the ordeal. And most of the time, when you're in a situation where the physicians and the healthcare team feel that care is futile, this becomes a big debate in the ICU. And like I said, I've seen various family members, various groups of people making decisions, making sometimes wrong decisions. And so we're going to talk a little bit more about this as we go along. So let's talk about some interesting facts. I'm going to ask you a few questions and tell me what you think. First question, are you comfortable withdrawing life support equipment from patients? So I guess you would call this a terminal extubation. I could tell you a story about me. When I first became a respiratory therapist, I wasn't even licensed. Back in 1991, I worked at a hospital, and they didn't require a license at this time in New Jersey. So what happened was I was a student. I was in the respiratory therapy program for about 3 months, got to know some patients at a hospital. I was mostly given nebulized treatments. And one day I was called to a floor with a patient that I knew. He was on mechanical ventilation. He was fully awake and alert. He had his own room. He, made good eye contact. He used to talk with a clipboard. He used to write notes on a clipboard. And one day I was called into his room, and they asked me to remove the ventilator from him. And I really didn't understand what they were talking about. And so they said, can you please shut off the vent? And again, I was like mystified, like, why would I want to shut off the vent? And then I was told, and there were family members there, or maybe about 10 family members, and the nurse pulled me on the side and says, this is what the family and the patient want. And then I realized what they were talking about. They were talking about, terminal extubation. And I really never did this before. This was my first experience. And to tell you the truth, I was a little bit offset with the whole thing. I had my own religious convictions, and back at the time, I felt that I was killing a patient. Like if I stopped that ventilator, I would kill him. So long story short, they convinced me, it was a Puritan Bennett 7200, I shut off the ventilator, and as soon as I shut off the ventilator, the whole room started crying, and the patient did not expire till about 2 hours later. I was horrified. That was my first experience with withdrawing life support, and over the years, as one of the managers in my department, I've dealt with a lot of different therapists who were uncomfortable with withdrawing life support. So what is your opinion? Put a message in Zoom in the Q&A. Let me know, are you comfortable withdrawing life support? Now, here's a second question for you. Do you ever feel that the care given to some patients is futile? As I mentioned earlier, I worked in surgical intensive care unit at a major trauma center, and I've dealt with a lot of patients who were terminally ill, who were, really aged, like 80 years old. The likelihood, after becoming a seasoned respiratory therapist, I had a good feel if someone was going to walk out of the ICU. And sometimes it was getting very frustrating to care for a patient who you knew was not going to come out of the ICU and most likelihood would die, and that would be called futile care. And a lot of times, if you spend a lot of time with patients who are in futile care, that means you spend less time with patients who might need you, like weaning someone from mechanical ventilation. If you spend a lot of time in a room with that patient who's doing futile care, and then you spend less time with weaning, they might spend an extra day on a ventilator. Who knows? But whatever the case is, did you ever feel that many of the patients you were taking care were futile care, and do you get frustrated with this? Here's another question for you. Do you ever feel that some end-of-life decisions are made with the interest of the family? In other words, the family's making the decisions. I've seen situations where a patient has told me in the past, I had a good life, I just want to go, I'm comfortable where I'm at, and yet the family wants to do everything in their power to keep the patient on mechanical ventilation or keep them on any kind of support they are. That is sometimes where decisions are made with the interest of the family members rather than the patient. Another question. Do you ever feel that patients suffering from serious chronic illness should have a living will or an advance directive in place? A lot of these problems could be resolved if the patient has a living will or an advance directive. And now I've seen scenarios where someone had an advance directive or a living will and they couldn't find it, and that's a whole discussion in itself. But I feel that if someone is chronically ill, they should have a living will in place, so this way they could really dictate what kind of care they want at end of life. Now, here's another question for you. Do you feel physicians are doing a good job with discussions with patients and family? I'm talking about futile care. I'm talking about end of life care. Do you feel that they are doing a good job? Are they getting the message across? Are they being effective with the family and the patient? Over the years, with palliative care and hospice care, I've seen it get better and better. I do remember a time way back in the beginning when I felt the conversations were not that good. Also, sometimes I feel that ancillary staff like respiratory therapists sometimes are not brought in to understand exactly what's going on with the patient. We're we're called, we're beeped, and we're told to come up and do a terminal extubation. Maybe we should have a little bit more insight on what's going on with the patient. Maybe we do. I'm not saying one way or the other. And then finally, we've seen death. We've seen suffering. We've seen people being treated with futile care. We've seen families falling apart. So with all of that, how many of you have a living will and advance directive? Now, if you could, this is a great question. Just put it in the Q&A and say, I have a living will, I have an advance directive, or say, I don't have one. And I'll give you a little insight. As much as I've seen everything, I don't have an advance directive. I don't have a living will. I'm a hypocrite. I could teach something, but I don't practice it. Why don't I have a living will? Why don't I have an advance directive? I feel I'm going to jinx myself. Very scientific. Yeah, I'm going to jinx myself. Real grounded in medical science. But I'm interested to know exactly what your position is, whether you have one or not. Please share this with me on the Q&A. Since this presentation is about communication of end of life, I wanted to talk about a study they did regarding CPR and mechanical ventilation with communications with physicians. So basically, they surveyed 1,500 patients, and they asked them, God forbid you're in a hospital and you have a cardiac arrest, something goes wrong, how many of you would like to get CPR? And of that survey, 70% of them said they would like to get CPR. 30% of them said they don't want it. So it was kind of clear exactly what people wanted. Now, then they asked the same group, did you communicate with your physician what you wanted? What do you want in regard to CPR if anything happens to you? Of that, only 23% of them discussed what they wanted with their physician, and 77% of them just didn't discuss anything with the physician. So the funny part here is that of this survey, 70% of the people wanted CPR in case something ever goes wrong, but they did not communicate this effectively with their physician. This is kind of alarming. The next slide is going to be talking about, suppose you go into cardiac arrest and you need mechanical ventilation. So with the same group of patients during the survey, they asked them if they went into some kind of medical emergency and they had to be intubated, and they were intubated for greater than 3 weeks, how many of them would want to stay on prolonged mechanical ventilation? Of this group, only 12% of them said, yes, I want to keep on mechanical ventilation. 88% of them said, no, I don't want to continue after 3 weeks. Then the same question occurred. How many of you have discussed what you feel with the physician? How many of you have shared your thoughts about that? And only 12% of them said that they spoke to the physician, and 88% of them said they did not speak to the physician at all. Of the 88% who did not speak to the physician, 20% of them felt the discussion would have been more appropriate if they talked to a physician. So the point I'm trying to make here, the communication of end-of-life decisions with physicians is very, very poor. People have one sense of beliefs, yet in reality, this is not really what transpires in a hospital setting. I am sure you all have heard of the Terry Shenfield story. Basically, this is a story of a patient, a 41-year-old woman who suffered brain damage from cardiac arrest from 1990. Basically, in 1990, she had cardiac arrest, she had a noxic injury to her brain, and she was in a persistent vegetative state. Her husband wanted to stop tube feeding in 1998. So from 1990 to 1998, they were debating whether she would come back, but in reality, she wasn't coming back. So the husband decided in 1998 that he wanted to stop tube feeding with her and let her go off naturally. He felt that he knows her well enough, and this is not what she would want her to be in a vegetative state. As a result of court decisions going in and out of court. They had 14 different court appeals. Her family, the mom and dad of Terry, said that no, they do not want to stop the tube feeding, yet the husband wanted to represent her side and say she wouldn't want to be like this. Let's stop the tube feeding and let her go off naturally. This was a huge mess. There was so many court cases about this, millions, thousands of dollars, I don't know if it's millions of dollars, was spent on this. Now, the truth is, if she had an advance directive or if she had a living will, maybe this decision would have been made. But this particular case about end-of-life decisions was one of the premier cases out there, which prompted a lot of healthcare practitioners, a lot of nursing homes, a lot of patient advocates to come up with some kind of advance directive on patients, especially with patients in vegetative states, such as Terry had. So this was a real mess. As healthcare practitioners, we know there's a lot of moral stressors. When you think about respiratory therapists and you think about nursing, you got to think about some of the stresses that come along with the job. Some of the stresses: continuing to participate in the care for a hopelessly ill patient when no one will decide to pull the plug. I am sure we all have seen this. This is your patients who are terminally ill, or they have no brain activity, or they're old and they have so many comorbidities that the likelihood to survive is very, very low. Yet no one in the family can make a decision whether to end life support for this patient. I mean, this is tough on the family, but this is also tough on us as healthcare practitioners. We have to take care of these patients day in, day and out, and the reality is we know they're not going to wean off the ventilator. We know they're not going to walk out of the ICU. They're not even going into an assisted living center. They are just hopelessly in the ICU, but no one wants to decide to pull the plug on them. Another big stressor: following a family's wishes to continue life support even though it is not in the best interest of the patient. For example, I've seen many families where you have different siblings agreeing or disagreeing on the care the patient has. You have an 80-year-old man who had a intracerebral bleed, who has pneumonia, who has COPD, who's on mechanical ventilation, and they just want to do everything. Someone in the family wants to do everything, and even though the mom of the patient or the brother of the patient or sister, whoever says, you know, dad's had a good life, why not we just give him the comfort, let him go out with dignity? Dignity is a key word here. This is a big stressor for us because we are in the middle of this. We hear both sides of the equation. We hear the family talking, we see the different positions here, and each of us have our own position too. Also, initiating extensive life-saving actions when it only prolongs death. I've seen patients who come in the ICU who are intubated and they decide to do a hip replacement on them when they can't even get off the ventilator. And, you know, these kind of extensive life-saving actions, or put them on nitric oxide, or put them on ECMO, or do any kind of these life-saving actions, but the likelihood of them walking out of the ICU, very low. And the idea, we have to do the care for these patients, so this causes a lot of stress on us. Also, following the family's wishes for the patient's care when you do not agree with them. I'm sure we all see this all the time. Family members say, why don't you wean my dad, or why don't you wean my mom from the mechanical ventilation? And obviously they have no kind of spontaneous breathing effort. And you try to explain to them that they're not doing well. They can't wean off the ventilator. But, you know, sometimes the family members are putting a lot of pressure on us. And then sometimes the final moral stressor is carrying out physician's orders for unnecessary tests and treatments for terminally ill patients. I've seen patients who are on mechanical ventilation who have fixed assist control, fixed settings, and every morning they want to do an ABG. Why? What are you doing? Weaning the patient off the ventilator? No. So we get these unnecessary tests. I've seen this done with CAT scans. I've seen this done with MRIs. I've seen patients being transported who are really not able to sustain any kind of life support system. So, it's really a problem. So a lot of times physician makes orders for things that are unnecessary, at least in our professional opinion, and a morning ABG on a patient who's not weaning from mechanical ventilation is a perfect example of that. So I have a good question for you, and I'd like you to put it in the Q&A. So we know about death. We know about suffering. We know about pain. We've been in the ICU. So with all of that, and we've seen family dilemmas, we've seen one family member going against another, we've seen futile care. So with all of that and all our knowledge, do you have a written plan stating what healthcare treatments you like or would not like in case you can't speak for yourself? In other words, do you have a living will? Do you have an advance directive? And if you don't, why don't you have it? What is your reasoning? So if you could put that in the Q&A, I want you to ponder on this question. It seems like, if anyone gets a advance directive, it should be us, because we're the ones who work in the ICU. We're the ones who've seen death. We're the ones who've seen suffering. We probably all know exactly what we want in life, or what we also want at end of life. So the question is, what percentage of us actually have a living will or an advance directive? Put it in the Q&A. So it's kind of interesting to note that most American, almost 88% of us, feel very comfortable discussing issues relating to death and dying. In other words, we know what we want, we know what our thoughts are, we know what we believe things should be, who should be our caretaker, all these things, yet only about 42% of us have a living will, and of that 42% of them, most of them are elderly, most of them are in nursing homes. So, we're all comfortable talking about it, but really, how many people actually have a living will? It's only about 42%. Death and dying in the United States. In the United States, there are 4 major paradigms. Some people look at death as a very natural process of life. You're born, you live, and you die. But in America, death has become medicalized. In other words, almost 70% of Americans die in a hospital, a nursing home, or assisted living facility. They don't die with their family next to them. Sometimes many patients die alone because they die in a hospital, they die in a nursing home, or they die in assisted living. They don't die at home. Currently, a lot of patients are dying at home with hospice. Hospice has shown to be a very dignified way of dying. So about 25% of us die at home, and most of the time it's done with hospice services, which I think is a very dignified way. Some people die by death on demand. What is death on demand? Death on demand is physician-assisted suicide. Many states across the country agree with death on demand. So the physician-assisted suicide can be utilized in a lot of states, and I'm going to get a little bit more detail about that on the next slide. So let's talk about physician-assisted suicide. When I first put this presentation together a few years ago, which I updated, I only had 5 states across the country that allowed physician-assisted suicide. As of today, 2022, there are 11 states that have legal physician-assisted suicide. Those states are California, Colorado, District of Columbia, Hawaii, Montana, Maine, New Jersey, New Mexico, Oregon, Vermont, and Washington State. Oregon was the first state to ever allow physician-assisted suicide. And how physician-assisted suicide works is that if someone has a terminal illness and they go to a doctor and the doctor says you have less than 6 months to live, and then that person goes to a second doctor who corroborates that diagnosis, they will be issued medication that they could pick up that will kill them. And basically it's a medication of barbiturates, and they also give another medication that prevents nausea. A lot of these patients who were given these super powerful barbiturates ended up taking it and vomiting, and then they had some kind of brain injury. So they really give something that will prevent you from vomiting but will kill you. 4 states, Alabama and West Virginia, don't allow physician-assisted suicide. I take that back. It's 2 states, Alabama and West Virginia, do not allow physician-assisted suicide. It's prohibited against common law. 4 states, Nevada, North Carolina, Utah, and Wyoming, don't have any specific laws, but they're a little bit on the fence. Palliative care is used with that. I have more to come with this, which we're going to get a little bit more into later. But physician-assisted suicide, you may or you may not agree with it. I know there's a lot of things going along with, everyone has their own religious beliefs on physician-assisted suicide, but luckily none of us have to make that decision. We're not terminally ill, we don't have a certain amount of time to live, and we're not in any kind of pain. So it's an individual decision. So what exactly is an advance directive? There are many different types of advance directives. There are living wills, there's a power of attorney, there's a bunch of different things going along with advance directives. But generally, it's a written statement of your wishes, your preferences, and choices regarding end-of-life decisions. So basically, when you're cognitively able to communicate with a loved one what you really want at end of life, this is the time to put it together. You can't put it together when you are emotionally distressed or if you're critically ill. You really need to sort of think about what you want, what exactly choices, what kind of medical interventions you want, how long you want these interventions, who do you want to be your power of attorney, who could speak for you when you can't speak for yourself. So this is a great tool for those who can't speak for themselves. Recent studies have shown that approximately 37% of all Americans have an advance directive of some form. It can also be a living will. And more importantly, roughly 40% of all seniors now have an advance directive. So I think as people get older and they realize that, you know, there is an end to life and what you want, especially if you're a senior citizen and you have chronic illnesses and you have repeated hospital admissions and discharges, admissions and discharges, you start thinking about your mortality. You begin to realize that everything is just not the way you expected. So seniors are the ones who predominantly get advance directives. There's a lot of education going on with nursing homes and assisted living facilities where patients are elderly, they have comorbidities, and they realize that, you know, they're not going to live forever. And the choices they make, while they're cognitively able to make good choices, they choose to create an advance directive. The person who speaks for you may not be your spouse, may not be your brother, may not be your sister. It could be your best friend, someone who you really know, someone who you trust, someone who knows you inside and out will sometimes be the person in charge of your advance directive. So it's very popular. It increases with the older someone gets, the more likelihood they're going to get an advance directive. And as someone gets repeated bouts into the hospital, gets admitted, discharged, admitted, that even more is a stimulus to get an advance directive. So let's get a little bit more detail about advance directives. As I mentioned on the previous slide, it's written instructions about what kind of medical care you want if you're hospitalized and you are seriously ill or injured and you cannot speak for yourself. Those are the criteria. So you have to be really seriously ill, you have to be injured, and really importantly, you cannot speak for yourself. There are different forms of advance directives, and I'm not here going to give you a big presentation on advance directives. They got living wills. Living wills are sort of watered down versions of an advance directive, a limited, you know, do not resuscitate, do not give me, do not put me on mechanical ventilation, do not intubate. These are common living will sayings. Another thing is you can have a medical power of attorney. A medical power of attorney is someone that gives you the legal right to make decisions on your well-being. They have another common thing is called POST. POST stands for Physician's Orders for Life-Sustaining Treatment. So if you're an elderly person and you have a lot of comorbidities, you might want to develop a POST order with your physician. And this could give you some basic guidelines. Do not intubate me, do not resuscitate. And commonly we all know about the do not resuscitate DNR order or DNI order, do not intubate. I'm not, like I said, I'm not getting into the nitty-gritty of advanced directives. I'm just here to give you a broad understanding of what they are and how they're utilized. There are several advantages of having an advanced directive. One of the ones is that you make your own decision. You could sometimes eliminate family squabbles, who makes a decision for you, or your spouse, or your brother, or your sister. And you could really make your own decisions on your own well-being. You could change an advanced directive anytime you want. Hopefully you do it before you end up going in the hospital and can't make a decision. Another important thing, you do not need an attorney. It's so simple to get an advanced directive. All you need to do is go do a Google search, type in advanced directives, and you could pull one down, fill it out, and get it notarized and submit the document anywhere you want. What's kind of funny about advanced directives? Sometimes they're not available for you when you really need them. I've heard many cases where someone came into the emergency room with cardiac arrest with their spouse, and where the spouse says they want to intubate the patient, and the spouse says, no, he has an advanced directive, don't intubate him. And they say, where's the advanced directive? And no one has an advanced directive. And all of a sudden, they intubate the patient, and 5 minutes later, the son comes in with the advanced directive, do not intubate. So this could represent a problem. I don't know why advanced directives, where they're stored, is such an issue. I know there's a national registry. There's a certain company that actually codes down advanced directives on their website. So if you're admitted to any hospital, anybody could go to this cloud-based website and pull down your advanced directive. I wonder why they don't have it attached to your driver's license. I mean, I think, when you talk about life-supporting decisions, you would think that someone could pull into a statewide database or a national database and pull up your advanced directive, and at least it will prevent issues like I just mentioned before, where husband and wife comes in and the wife is saying do not intubate him, but she doesn't have the document with her. It's stored at home in some file cabinet. So this represents a problem. It's getting a little bit better, but I'm surprised they really haven't addressed this fully. So let's talk about the disadvantages of advanced directive. As I was just mentioned, it may not be available when you needed it. So in a situation like I just mentioned, the husband gets a cardiac arrest, comes into the emergency room, physician feels they want to intubate him, the wife doesn't have the advanced directive with her, that's a problem. Someone could be in an ICU and they can't find the advanced directive. They know they did it, it's somewhere at home, but they can't find it. Another problem is not available all the time on patient charts. We've gotten a little bit better with the electronic medical record, where now advanced directives are stored on there. But think back not long ago when we were paper charts, to find an advanced directive was a printed note in a certain section in a physician's chart. So with the electronic record, it has become a little bit more available, but with the paper record, it's not. Sometimes it's very restrictive in decisions. Some people have advanced directives and they didn't really think it fully through, that they restrict certain life-sustaining decisions going on. So the point about an advanced directive is when you do it, understand exactly what you want, all your options. Everyone should know exactly what they want. And how about you change your mind about the care you are receiving? You might be too late. Suppose you have an advanced directive and you say, do not intubate me, but the truth is, if you intubate them and you maintain them up in the ICU, they could be discharged 5 days later. So sometimes changing your mind about an advanced directive because it's so stringent on certain rules, like do not intubate, do not resuscitate, could be, could kill you. So that's some of the disadvantages of an advance directive. So what is a living will and how does it differ from an advance directive? And a living will is a form of advance directive, but is not as complete as an advance directive. Advance directive is like a broad term used, and it goes into much more details about the care you receive. When you think about a living will, it's kind of an abbreviated advance directive. It tells you what kind of medications you want. Do you want to be intubated? Do you want to be resuscitated? But it doesn't get into the details of how long you want to maintain mechanical ventilation or what kind of new medical treatments you might want to consider, which would come with an advance directive. It only becomes effective when you're incapacitated, but you get to choose what you want to do, what you want, and it also gives you a choice of what you don't want. But the difference between a living will and an advance directive is an abbreviated version of the advance directive. So some of the confusion between a living will and advance directives will be outlined on this slide. As I mentioned before, a living will is a more limited type of advance directive. They're both advance directives, but the living will is limited. It will mention do not resuscitate, do not intubate, do not offer tube feeding, do not transfer me to a nursing home. So it's going to get into those kind of simple decisions. But when you think about an advance directive, which is probably the better of the two, you can name a proxy. That's someone who could speak for you when you can't speak for yourself. It could tell you about life-sustaining procedures in the event of terminal condition. So suppose you say, I don't want ECMO, or I don't want a heart transplant, or I don't want a kidney transplant, or I don't want a liver transplant. You can make those decisions with an advance directive where typically a living will won't have it. You could do, you could do not resuscitate, do not intubate orders. You could also, with an advance directive, which you typically don't do with a living will, suppose you go into a vegetative state, a persistent vegetative state, where you don't respond for a long period of time. You can make decisions so that if you're in this persistent vegetative state for 90 days, that you will end all kind of tube feeding, you will end on kind of mechanical ventilation, any kind of thing, or any kind of artificial hydration. So in other words, these things will come in the form of an advance directive rather than a living will. And also when you're in end stage conditions, you could talk about, exactly what you want. Like I told you before, you could think about a kidney transplant, you could think about a liver transplant, you could think about a heart transplant, you could think lung transplant. Maybe these kind of things have to be mentioned in an advance directive, where a living will would be just more do not intubate, do not resuscitate, not making some big decisions on what you're doing, some major ones, but not as quite as comprehensive as an advance directive. So what is a medical power of attorney? A medical power of attorney is a legal form that states who you want to make decisions for in your medical care. In other words, this is the person who could speak for you when you can't speak for yourself. A lot of times a medical power of attorney could be called a healthcare proxy or agent. It could be a healthcare surrogate. It could be durable power of attorney for healthcare. So these are all the terms. So when you think about a medical power of attorney, think about someone, and it doesn't have to be your spouse or your sibling, someone who could speak for you in your wishes and what you want. There are various terms used in end-of-life care, and I just wanted to give you a little more understanding of them, such as life-sustaining treatment, artificial nutrition and hydration, cardiopulmonary resuscitation, a DNR order, a DNI order, palliative care, and hospice. As we go along with further slides, I'm going to go a little bit more detail about each of these terms. I also want to talk about the ethical challenges of end-of-life. Some of these can include decision-making capacity. There's a difference between withholding treatment and withdrawing treatment. I'm going to talk about the doctrine of double effect. I'm going to talk a little bit about the ethical challenges of artificial nutrition and hydration. I'm going to talk about futility or futile care, and I'm going to talk about physician-assisted suicide and euthanasia. One very important factor of end-of-life care is assessing the decision-making capacity of the patient. You have to make sure that the patient is competent versus decisional. Anybody could say, yeah, I don't want to be intubated. I don't want to be intubated. But the point is, are they competent? Do they understand the consequences of their action, of their words? So testing the decision-making capacity of a patient or family is really important. When I say testing, you have to be able to let them communicate. They got to be able to communicate effectively. They have to understand the treatment options and the consequences of not doing those treatment options. They have to be able to grasp the consequences or declining therapy. And they have to be able to reason. So if someone can't reason, they don't understand the consequences of declining therapy, they're not able to communicate effectively, you cannot have them sign off on something that could end their life. So these are some of the determinations of decision-making capacity, which is very important. Dying and end of life is a very sad state of affairs for anybody. Any one of us, if we were dying, if we got a diagnosis that we are terminally ill and we're going to die, obviously there's going to be a certain level of depression. And depression can be sometimes cloud your decisional making capacity. Sometimes you just want to throw in the towel. You don't want to do anything about it. Sometimes when you need to involve a professional such as a psychiatrist. Also, sometimes you may have to involve a surrogate. So, if someone is depressed, you have to have them evaluated by a psychiatrist, and you have to understand that everyone, or every normal person, I think, would, to a certain degree, would be depressed about dying. You might need to bring in an ethics consult. You might have to be careful about the limiting or withdrawing of care to these patients. So you really have to get a better understanding of how these people feel. And different people of different ethnics and cultural variations have different responses to things. So assessing the decision-making capacity of a depressed patient is really important. You can't decide that their decisions are the best, but sometimes they can make good decisions. So you really got to look at this very, very closely. So what do I mean by withholding versus withdrawing treatment? Basically, morally and legally, they're equivalent, but there's many factors that go in with it that make it a little bit difficult to understand. When you withhold therapy or withhold treatment to the patient, you are actually not giving someone life-sustaining treatment. Like suppose you decide not to intubate somebody. That is, you did not intubate them in the first place. You're withholding therapy, and potentially, they could pay the consequences of that choice. Withdrawing therapy is different because what happens is the patient is intubated, and at this point you decide to withdraw and extubate the patient, which is a terminal extubation. Both of these things are morally and legally equivalent. Both of them impact the patient a different way. For example, if I was told not to intubate a patient because they have a do not intubate order, I really don't give it much a second thought. I think about the fact that, they didn't want to be intubated, they made a choice, and I'm comfortable with that. I feel comfortable with that. But suppose that patient's intubated, and then the family member comes by and says they shouldn't have been intubated. They have a do not intubate order, DNI order, but here it is, and now I have to extubate them. I'm going to go through some moral stresses with that because what I do will cause death to the patient. Withdrawing care is much more emotionally difficult than withholding care. Withholding care in the presence of a living will is much easier. So if you have an order, do not resuscitate, do not intubate, you could hold back. You feel better morally. But if you have to withdraw care that potentially results in their death, this is an emotional hurdle that you have to get over. There's a term called the doctrine of double effect. And what that means is that you could apply an intervention that could potentially harm the patient, but in the long run, it would help them. So you're saying, what is he talking about? So the idea is you potentially do some form of harm to the patient, but in the long run, it's for their betterment. So I'll give you an example of this. A perfect example of this would be to give a morphine bolus to control pain on a patient. Suppose you give morphine to a patient because they are suffering, they're at the end of life, and you want to just sort of relieve of the suffering that they feel, the pain they feel. But someone feels that if you give too much morphine, you could suppress their respiratory cycle and kill them. So this is an example of the doctrine of double effect, where you give something to relieve their pain, but potentially it could cause harm to them by the fact if you give too much of it. But the whole point of this, your priority, is to relieve the suffering and pain at end-of-life decisions. This is an example of the doctrine of double effect, where you could potentially do some harm to the patient. There's a big debate going on about artificial nutrition and hydration at end of life. But there's a difference between palliative care and hospice care. Basically, with hospice care, you want to withhold nutrition and withhold hydration. And that may seem like very mean and harmful to the patient, but it's the best thing, and I'm going to get a little bit more into that. Someone who's on palliative care can get nutrition, can get hydration, and they should. But you should speak to someone who has in hospice, and why are they not getting hydration? Why are they not getting food? Why is my family member not getting it? And you really got to let them understand the consequences of hydration and nutrition with hospice patient. And I'll talk about that in the next slide. There's strong evidence that patients who are at end of life should be withheld from getting any kind of hydration or nutrition. And why is that? Typically, these patients do not have much thirst. Number two, you should restrict fluids because they don't cough as much. They have less chest congestion and pleural effusions. They have decreased urine output, so you don't need to do catheterizations. So for all of these reasons, patients in hospice, you really need to withhold nutrition, withhold hydration, versus someone who's in palliative care, which you would not withhold it. Some of the benefits of withholding nutrition and hydration with patients in hospice is there a decrease in GI fluid and bloating, no diarrhea, decreased leg edema and pain. So most of these patients should be withheld from hydration. The funny part is, in acute care hospitals, they hydrate these patients. They suffer from congestion. They suffer from GI bloating, all of these things. So, but with hospice patients, withhold no fluids. The problem with palliative care or some hospitals with people who are dying, they ended up giving them fluid. I'm going to briefly talk about medical futility. I have a whole PowerPoint on medical futility, which I give 35 slides on. This is one slide. Any course of treatment that provides no medical benefit to the patient or any kind of benefit to the patient is medical futility. Medical futility actually doesn't improve the outcome of the patient. So why treat the patient? Why create suffering in the patient? Why create expense for the family when you don't have to? So medical futility is something you got to watch, especially with end-of-life care, because you don't want to treat the patient with the anticipation of becoming better when there's no likelihood of that ever happening. Let's talk about physician-assisted suicide. Jack Kevorkian, Dr. Jack Kevorkian, was a physician who first performed physician-assisted suicide with a woman with early Alzheimer's disease in Michigan in 1990. He actually did this procedure on 40 other patients who he euthanized them. He did physician-assisted suicide. Then on 60 Minutes, he actually broadcasted across America euthanizing a patient. he was convicted of second-degree murder and jailed for 8 years. While 60% of people who are terminally ill support physician-assisted suicide, only about 11% consider it. So he was a pioneer in physician-assisted suicide. As I mentioned before, the states listed above have approved physician-assisted suicide, and it all started in the Oregon state with the Oregon Death and Dignity Act, which was passed in 1994. Basically, patients with a terminal illness with less than 6 months to live by a physician requested to get physician-assisted suicide. They needed a second opinion from a physician, and they also needed to have 2 witnesses attest to the patient's competence, and one of them could not be a family member. So basically, as a result of this law passed in 1994, and because of the criteria listed above, the law was used in Oregon extensively. California sort of picked up on the law that was started in Oregon and sort of refined it a little bit better, so did New Jersey and these other states. But Oregon is the first state to utilize physician-assisted suicide, and it's done it many times. Physician-assisted suicide can be good and it can be bad. I'm not here to say if it's good or bad. It all depends on the choice. Some of the problems with physician-assisted suicide is it felt that it could be utilized for uninsured and underinsured patients. When patients can't pay for medical care and they're in a vegetative state, it becomes very appetizing to certain organizations to sort of end their life with physician-assisted suicide. So think about it. Uninsured, underinsured patients are at risk. Sometimes it also could be a risk factor for patients who are not decisional. So if someone's not making competent decisions and they elect for physician-assisted suicide, that could be a problem. Another problem is, and this happens a lot of patients who are dying feel they are a burden to the family. They feel that they're a financial strain, an emotional strain, and they want to end their life so that they could avoid pain to the family members. And that is wrong. I mean, me personally, I find that really wrong, but this is a concern to patients. Another big concern is that society may be ridding itself of the vulnerable and dependent population. So there are certain people who may not benefit from great medical care because they just don't have the money, they don't have the resources, or they don't have the family members supporting them. So these are some of the problems with physician-assisted suicide. I have a whole presentation I do on physician-assisted suicide, and I know I rushed through this, but I just want to give you the side of physician suicide that is typically dark. End of life, there are certain ways that you could speak about situations. This slide is going to talk about how to communicate with end of life situations. And I'm going to go over each one in detail. Number one, you introduce the conversation. If someone is dying, you have to introduce the conversation. Part of the process is to explore personal beliefs and values. Also, you got to define your end-of-life wishes. And most importantly, you got to document your wishes. Where do you document? An advance directive. So let's continue. So how do you bring up a difficult concept or difficult conversation talking about dying and end of life and advance directives? It could be done in a number of ways. Sometimes you need a conversation trigger. A trigger could be you meet with family members and you have a little party and they talk about, did you hear about Uncle Joe dying or Aunt Kathy dying? You could also talk about the death of a friend or a colleague. You could saw a movie. You might be at your place of worship and you hear a sermon. You could be watching TV. You could be talking to your financial planner. It could be done in your medical checkups. Each of these incidents are a trigger. This brings up the thought process, like you don't want to hear anything disastrous at this time, but you want to hear about Were they prepared for this? So each of these particular triggers could bring up the conversation, and this is when you could start the engagement or start the process of thinking about what you need to do. So now that you have the trigger and you want to think about the conversation of end of life and what to do, an advanced directive, you bring up the conversation, you introduce the conversation. Timing is everything. You really want to do this in a private, comfortable place. You also want to ask for permission to bring up the topic. You know, if you have a loved one you know is chronically ill, you know, you have to sort of get their permission that you talk about it. You could begin with that conversation trigger, like I told you. It could be a family gathering, it could be a movie, it could be a sermon you hear. Something has to trigger the conversation. You do it in a private place. And what's really important is to express end-of-life wishes. You really want to understand their feelings about this. So this is a very important part, introducing the conversation. The second part of this conversation is to explore personal beliefs and values. You have to engage in a conversation about the patient or the family member's beliefs and values. What makes them happy? What are they happy in life? Did they do everything they wanted to do? Talk about their challenging times. How did they deal with it? How did they deal with challenges? What gives them strength? Spirituality. What do you believe in? Do you believe in the hereafter? Do you believe in, you know, whatever your spiritual faith is? Are you comfortable where you are? Are you comfortable with your family growing up? Do you have good memories of your family ones? Also, what makes life worth living? You know, if your life quality is not what you expect it to be, maybe you want to talk about this. You also might want to talk about your lifetime legacies, things that you've done, things that were positive, maybe even things that were negative. In other words, you want to rehash what goes on in life. This is exploring your personal beliefs and values, and this is a good way to engage in a conversation, and it's a very open conversation and hopefully a very truthful one. This is when we get down into the nitty-gritty. You want to define your end-of-life wishes. For example, where do you want to spend your last days? Where's your bucket list? Who do you want near you at the end of your days? In other words, do you want your significant other? Do you want your family members? Do you want certain friends there? What do you want? Who do you want? Who's going to speak for you? Maybe this is where you introduce the concept of a proxy. How you want to spend your days. If you are sick, do you want to spend it at home in hospice, or do you want to spend it in the hospital with palliative care? You have to make your decisions. What kind of medical care do you want? Do you want everything done for you? Where is the limit of your medical care? So these are the kind of conversations where you define your end of wishes, you know exactly what you want, you're cognitive of everything you want, and then you put it in paper. This final slide talks about expressions of grief. When a loved one dies, you go through different phases. The first phase is numb. You feel distressed, you are in disbelief, you can't believe what's going on, you're just numb or you're in shock. After a while, you come to the second phase, which is basically emotional turmoil or depression. You think about the loss you have, and you think about all the good times, and you think about what you could have done differently. And, you know, this is a normal process. Finally, you're in the third phase. And the third phase, you reorganize your thoughts, you're resolute about what you believe, you think about the positive things that went in life with your family member or friend, and, you know, you get better, you heal. So remember, grief is a series of steps. You go from numb, you go from depression, you go to resolution. These are a normal process, and everyone's time factor for these processes take a different amount of time. I want to thank you all for joining my presentation and hope you learned something from it. This is a topic that as healthcare practitioners we deal with every day at the bedside. So I think it's important for us to understand how to communicate at end-of-life decisions, a little bit that goes along with the decisions. And I listed here some good references that you may want to look up if you want to learn a little bit more. And again, I want to thank you all for joining me, and you have a great day.